Good afternoon, everyone. Today we have Dr. Snehadrit Mukherjee, a renowned orthopedic surgeon having close to 15 years of experience in Kolkata. Welcome to Vitadell, sir.
Thank you. I am Dr. Snehadrit Mukherjee. I am an orthopedic surgeon with close to 15 years of experience, and I deal with all kind of orthopedic problems. And I have recently associated myself with Vitadell Healthcare, and I want to share something with all my viewers.
So what is the difference between a sprain and a fracture, and how do I know which one do I have?
Well, as far as the definition goes in layman terms, a sprain is an injury exclusively of the soft tissues like the ligaments surrounding the joint. So depending on the degree of the sprain, it might be an elongation of the fibers or partial rupture of the ligament or a complete rupture, but usually doesn't involve the bones. Fracture, on the other hand, is a discontinuity in the continuity of the bone. The normal anatomical bone is broken at one or more places. So both of these conditions are very similar, as for example a very high grade sprain or a low grade fracture will present in a similar manner, like swelling, like bruising, like warmth, like extreme tenderness, inability to walk or bear weight. But for fractures which are of major degrees, there are certain things which are not usually seen with a sprain, like undue mobility at the fracture site. Number 2 is extreme pain. Number 3 is absolute lack of function of the arm or the limb. So in most cases, fractures can be decided on clinical grounds from a sprain, but again in very lower degrees of fracture and high degrees of sprain, it's sometimes very difficult, which is why we always order an X-ray in order to be sure whether it's a fracture or a case of a sprain. Very common in cases of ankle.
Sir, if I break a bone, how will the doctor decide whether I need a surgery or a cast?
Well, there are certain things which are taken into consideration, like if the fracture is undisplaced, usually for smaller bones, where there is no severe degrees of comminution. I mean, it has not broken into multiple parts and it is more or less in place, only broken. Then we and if the patient has is in the extremes of his or her age and there are morbidities associated with surgery, like renal failure patients, like severe coronary compromise, etc., then we have to strike a balance. In those cases, we put on a cast or a plaster. But for most displaced fractures where it is not anatomical and the gap is so huge that if we don't do anything, it has very low chance of uniting, then we go for fracture fixation by surgery. Nowadays, compared to what we used to have 30 years back, most surgeons now prefer surgery for most of the fractures because of certain advantages associated with surgery, namely faster rehabilitation and better placement of the fracture ends with one another.
So what is a cartilage and why it is so important to repair that once it is damaged?
Well, cartilage, to put it very simply, is a lining, a covering which is present over and above the end of the long bones. Even smaller bones have cartilages, so it's just a protective film over the raw bone. Now, cartilages, the intention of having cartilage, as God has provided us, is to provide a very smooth medium where the joint can glide and operate, and it is almost a frictionless system. And without the cartilage, as it is very much evident from what I have said, the raw ends of the bones will start rubbing against one another, and in no time they will get eroded. And there will be immense pain because the end of the bones are richly supplied with pain-sensitive nerves. So what cartilage does is that it acts as a shock absorber, it acts as a buffer, and it provides a frictionless system for the mobility to occur. Now, cartilage injuries, they have many classifications. So it can range from having a very soft and frayed cartilage to a complete thickness depth defect where the raw bone is exposed. Depending on what kind of injury or damage that has occurred to the cartilage, the treatment varies. It ranges from repairing the cartilage or sewing it up, and we can treat it by microfractures or even cartilage grafting is now also a possibility. The same thing acts for ligaments, especially for knees. There are certain cartilages which has got a very good blood supply, and it's expected that they heal in young patients. But the same cartilage also has a very poor blood supply when you consider other parts of that cartilage. Those types of cartilage injuries usually require surgeries.
Sir, why do some patients need metal plates and screws when they break a bone, while others do not?
As I have said earlier, it all depends on which bone has been fractured, whether it's displaced or not, whether there are multiple fragments or not, and many other things. So there are clear-cut classification systems telling us what to do and what not to do. In case where we have a fracture which is usually not displaced, it's only a break in the bone, but it has not got displaced. There are no multiple fragments, and the ends of the fracture are more or less facing each other anatomically, and patients are elderly and there are morbidities. Then we usually go for conservative treatment like a cast. It's very common for wrist fractures in elderly, where most patients still now are being treated with a manipulation under anesthesia and cast application. Even the collarbone fractures are mostly treated in this manner, conservative. But when the displacement is great, or there are multiple fragments, and it's not expected that the fracture heals by itself without any intervention on part of the surgeon, then we have to fix it by metallic implants. Now, a nail or a plate has specific indication of its own. There are fractures which can be plated or nailed, but usually long bones are nailed, and there are certain instances ends of the bones which are plated. That's completely a different thing, which implant I am choosing, but this is the difference when we go for conservative treatment.
Sir, how long do I wear a cast if I have a small fracture, and what would happen if I take it off early?
There are recommendations, like for the upper limb we should wait for 6 weeks, for lower limb it's 12 weeks, for children it's almost half the value. But this is not a very hard and fast rule. I mean, where it has been said to wait for 6 weeks, there will be some patients who heal their fractures at 5 weeks, and there will be some patients who heal at 7 weeks. So this is number one. Firstly, there is a recommendation. We have to follow that rule, that we have to keep this plaster for 6 weeks, 8 weeks or 12 weeks, and it can be modified a bit. What is the disadvantage of removing the cast earlier? What happens is that, say for example, a fracture was uniting with a cast. Now somebody decides that, well, the cast is causing problem and I'm going to remove it, and he inadvertently removes you. Then what happens is that the fracture which was still now uniting may go into a non-union. Then actually it fails to unite. This is known as a non-union. It may go into a delayed union. Say for example, it was intended to heal at 6 weeks. It starts healing and gets healed by 3 months. So delayed union is a possibility, non-union is a possibility, persistence of pain is a possibility, and loss of function as a combined effect of all these things is a possibility. It's not recommended to remove a plaster till the signs of healing are evident, both clinically and radiologically.
Slap immediately provides some stability to the fracture, so there is reduction of pain. It also helps in reduction of swelling, reduction of warmth, and as a consequence of all these things, the pain reduces.